My first realization that this intersection between pain and addiction was common and complex was when I started as a faculty member in my role as the medical director of a methadone maintenance program. And it became quite apparent to me that many patients who were coming in for addiction treatment for their opioid use disorder, requesting methadone as their treatment, described that their history all started when they were prescribed an opioid for some pain issue. When I started exploring it a little bit more with individuals with an opioid use disorder, many of whom who still had pain, when they described their experiences in the hospital, it was horrific. What seemed to be happening was that the healthcare provider team, the providers, were fearful that they were being, scammed, but also that they would worsen the addiction, perhaps. And then the patients were fearful that they were going to be mistreated or undertreated because of their history of addiction. And it turns out that from experimental studies where they do these pain studies in individuals who have a history of addiction versus those that don't, it seems pretty common that patients with a history of addiction have increased sensitivity to pain. They have a lower tolerance to pain. So not only do they experience pain, but it's more severe. And so I think we as healthcare providers need to appreciate that and be really aggressive in our pain management. And it turns out that aggressively treating pain is not dangerous. In fact, it will keep the patient engaged in care, and it's the humane thing to do.
Pain and addiction intersect at multiple levels. Patients who are prescribed opioids are at risk of developing an opioid use disorder, and patients with an opioid use disorder are at risk for suffering from severe pain. In the United States, approximately 25 million people have either moderate or severe chronic pain. According to the Institute of Medicine, negative attitudes and health disparities are significant barriers to pain care. Currently, the U.S. has two simultaneous crises: the undertreatment of pain and an increase in opioid overdose deaths associated with opioid overprescribing and increased availability of illicit opioids. In a survey of community physicians, nearly 90% reported that the fear of causing addiction prevented them from prescribing opioids to patients with chronic pain. In a systematic review of patients with chronic pain receiving chronic opioid therapy, approximately 25% misused their prescription opioid and approximately 10% showed signs of opioid use disorder. Risk factors included mental illness or a personal or family history of substance use disorder. When patients are on chronic opioids for treatment of chronic pain, it can be difficult to diagnose an opioid use disorder. Is the patient's unauthorized dose escalation and/or compulsive drug taking a result of an opioid use disorder? Is it the result of unrelieved severe pain? Or is it a combination of both? This can be difficult to sort out. Pain plays a substantial role in both initiation and continuation of illicit drug use. A primary care-based study found that over 50% of patients using illicit drugs reported doing so to treat chronic pain. Over 50% of individuals seeking or engaged in treatment for opioid use disorder reported having moderate to severe pain. Experimental studies show that people with a history of addiction are more sensitive to pain than people who do not have a history of addiction. Whether these individuals are born less tolerant of pain or whether their increased sensitivity is the result of their opioid use disorder is unknown. Research has shown that patients with a substance use disorder seeking treatment for pain and the providers treating them may experience anxiety specific to this situation. Providers were fearful of being deceived by their patients, and patients were fearful that they would be mistreated because of their history of addiction. Managing pain can be even more challenging when a patient is being treated with methadone or buprenorphine for an opioid use disorder. It is important to remember that methadone or buprenorphine, dosed once per day to treat opioid use disorder, will not control pain. To properly manage acute pain, it is crucial that methadone or buprenorphine treatment be continued while a patient's pain is aggressively managed with usual analgesics, including opioids when indicated. Sometimes, due to a patient's increased pain sensitivity and cross-tolerance between the methadone or buprenorphine treatment and an opioid analgesic given for pain, a patient may require higher opioid doses at shorter dosing intervals. While we've made progress in addressing pain in patients with opioid use disorders, we have a lot of work to do. Healthcare providers should discuss pain with all patients who have a history of substance use disorder. Providers should let patients know they will likely be more sensitive to pain due to their history and reassure them that their pain will be aggressively managed, all while keeping them safe from the negative consequences of opioids. This conversation should help alleviate anxiety that patients with chronic pain and a substance use disorder have while interacting with the healthcare system.